A few other anatomical considerations that we need to make when we're looking at the rehabilitation of the shoulder is that the shoulder isn't a very simple joint. It's not like a hinge joint where we can say, oh, this muscle is doing this or anything like that. We have 17, sometimes 18 muscles that attach to this bone, the scapula alone. And when we look at this bone, the scapula, and how it's actually connected to our body, it's really not connected very well. So we don't have any true articulations that connect our scapula to the body besides this one right here. And this is our AC joint, or our acromioclavicular joint. Right here we have the bony acromion, and then this is our clavicle, which is the most fractured bone in the human body. And these come together to form this tiny joint right here. So if you ever hear about someone separating their shoulder or getting an AC joint sprain, that's to right here. So that's a sprain to the only thing that's really holding this piece of anatomy to our body. So our humerus is connected to that scapula, and all of these different things, all these different muscles have to work in concert in a coordinated fashion and as a functional unit to help us and allow us to do the things that we want to do with our upper extremity. So when you're rehabilitating this, it's important to look at this as a functional unit and not individual muscles acting to do individual things. Actually, research shows that even when we adduct or bring our arm to our side like this, the external rotators or some of these rotator cuff muscles are still activated because they have to be the ones that centrate this humerus into the glenoid fossa in order to provide stability and support while we do any kind of movement, even if it's the opposite of what we normally think of as this muscle action. So I hope that's an interesting tidbit of information, and I hope you guys enjoy.